We're going to explore international electives for final year medical students. In the US, that's for fourth year students. In many other settings, that's for 6-year students. We're going to explore some fundamental principles and partnership principles and CFHI offerings as well. I'm really excited to be joined by Gonzalo Clare, Dr. Kanyanta Kameka, and I hope that Michaela Whitelaw will be joining us as well. She's an alumni and medical student at Emory. Gonzalo and Dr. Kameka, could you introduce yourselves and tell us a bit more about you?
Doctor, go ahead, please.
All right. Hello, everybody. I am Dr. Kanyanta Kateka. I am originally from Zambia, and I did my med school in Cuba. I was part of the cohort for the virtual elective that Child Family Health International CFHI organizes. And I was a part of this during the March elective for 2025. That's where I got the chance to meet all these lovely people that you see with you today. And so I'm happy to be here to talk about my experience with the elective and obviously be of help in case of any questions regarding any electives that anybody may have.
Okay, my name is Gonzalo Claure. I am based in the city of La Paz in Bolivia. I am actually the local coordinator for programs, for CFHI programs in La Paz, Bolivia. I've been working in this quality since, I don't know, about 23 years ago. So I've seen CFHI grow a lot. I'm very happy to be here. Thank you very much for having me.
Wonderful. And we have Morel Hancock, who is CFHI's Outreach and Communications Coordinator, who is making this possible. So thank you so much. Um, we're happy to take questions or comments as things go, and we'll hopefully also have some time at the end. But feel free to use that chat function and check out some key updates in there as well. Hopefully, Michaela can join us. As we know, last year of medical school and rotations can be unpredictable. So many of you know CFHI. I went abroad as a medical student, and I didn't really know much about the organization that was facilitating my experience. So I hope that those of you who don't know us will get to know us over this hour. CFHI precedes both Gonzalo, who's been here for 23 years, and myself. I've been with CFHI for 17 years. We were founded by Dr. Evelyn Jones, who is a family physician at Stanford University, and she founded the organization after organizing an elective with Dr. Edgar Rodas, who was a surgeon that was committed to health access through mobile rural surgical units in Ecuador. She rotated with him, and she realized that she had gone with a framework of thinking she was going to change the world during her international elective. She came back realizing that she got a lot more out of it than she was able to contribute. She started CFHI, and our tagline is "Let the world change you." That tagline is what drew me to the organization. I have a background in anthropology and really spoke to how I kind of see global engagement, particularly in our early steps. CFHI now has programs for undergraduate, graduate, and postgraduate students in 10 countries. We have over 16,000 alumni. We have 16 electives that I'm going to talk later about and competency aims. We have both direct enrollment, so students who are on this, you can actually apply and enroll directly with CFHI, but we also have partnerships with over 150 universities so that many students can benefit from collaboration between your university and CFHI. Sometimes that enrollment is done on the university side and sometimes it's done on the CFHI side. So if you have specific questions about whether your school has a partnership, happy to talk about those. In terms of where our global health electives are, spoiler alert, these are all the locations. So they're across Latin America, Sub-Saharan Africa, and Southeast Asia. I'm going to talk about the specific themes, but first I want to make sure that we're not taking for granted some of the foundational concepts in global health. And I see that Michaela joined us. Michaela, welcome. I want to make sure we can hear you.
Hey, yeah, sorry, I was muted.
No worries. I had Dr. Kaneka and Gonzalo and Morel introduce ourselves. Do you mind introducing yourself just
Yeah,
briefly?
yeah, for sure. My name is Michaela. I was about to say fourth year med student. I am a first year intern, PGY1 for Med Peds at Rush in Chicago. And I was at school in Emory in Atlanta. And I was in Tarija, Bolivia last September.
Great. I'm looking forward to hearing your thoughts on that rotation. And I have a slide for you to correct any inaccuracies I have. So Morel and Gonzalo and I are representing the CFHI global team, but I just wanted to mention our positionality of really having a lot of privilege to be able to be the face and the voice of the organization. There are many, many, many more folks on the ground who make the rotations possible and who account for the CFHI global team. Here are some of them pictured, and I just want to recognize that we are really on their backs and they are doing the work, and we get to shout from the rooftops. In terms of the concept of global health, oftentimes international electives are seen as separate from global health. In some universities or medical schools, there's more cohesiveness. I think that's changing a bit, but international electives and rotations in general sometimes live in their own silo, and then global health lives in another silo. I want to today kind of bring those concepts together because often international electives are happening in lower resource environments. So if you're from the US, they're often happening in low and middle income countries. These are World Bank designations for GDP. And so because they're happening in lower resource environments that have often been prior colonized and or have disadvantages socioeconomically compared to the United States, there's a lot more going into our electives and there's a lot more context than maybe we realize as students or even our med schools may realize. Global health is a concept that was formally described or defined in the Lancet in 2009. And actually led by a dean at Emory, this article was published to try and give definition to an emerging field of study and research and practice that really focuses on health equity and working beyond just a clinical lens, merging with public health and attention to transnational health issues and broad determinants of health, including social, governmental, and other determinants of health. So what I think is interesting about that definition is that it was put forth at a meeting in 2008, although it was published the following year. And they were kind of brainstorming amongst a group of folks who gathered at the Consortium of Universities for Global Health. And they were brainstorming, how do we define global health? What are ideas that are in the room? Well, that very nice, lengthy, beautifully worded definition got published, an alternative definition was put forth by a Kenyan physician. And he said that global health is, quote, a concept fabricated by developed countries to explain what is regular practice in developing nations. And I just wanted everyone to take a moment to reflect on these two definitions and potentially the contrasts between them. Um, when I read that second definition, there's certainly a spirit and potentially a concern there about who is defining global health, whether we are fabricating others' realities, and potentially a power imbalance between high income, which previously were called developed, and low and middle income, which were previously known as developing countries. And so as we kind of hold space for that critique and those concerns, I want to unpack a little bit more where that might be coming from and how we ensure our international electives do not replicate that potential fabrication that's so common. So some key concepts that are going to be interwoven in this initial discussion. One is decolonization. What does that mean? Why is it relevant? Number two is a concept called the credibility deficit. Three is a psychological concept called the oversimplification cause fallacy. Number four is actually a community development, international development approach called asset-based community development. And then lastly, I want you to think about the competencies of what you're aiming for when you go on an international elective. Um, and let's think about how that merges with this potentially colonial endeavor. Global health is really criticized for upholding colonial structures and reinforcing power imbalances. And so, if you are going abroad during your fourth year, particularly to a previously colonized location or a location that has less power and privilege than the United States does in the world standing, really thinking about what you may be bringing with you in terms of your own assumptions, mentality, understanding, but also what context you may be entering into. When it comes to credibility deficit, I don't think um, anything I could tell you academically would emphasize it enough compared to this statement by these two medical students. I wonder, Michaela, can you see that? Could you read? This is from a medical school magazine. Do you mind reading it out loud for us?
Yeah, sure. Credibility deficit. Dan and Christopher spent much of the summer caring for people in remote villages of Tanzania where medical professionals seldom are seen. With little supervision from physicians, they traveled village to village, caring for patients suffering from malaria, HIV, chronic pain, and other illnesses. Just being thrust into a situation like that made all of the classes we took that first year very real. You learn quickly that way because you don't have a choice.
Thank you. So I'd love to hear, you can probably imagine what a credibility deficit is, but can anyone in the chat function maybe ruminate or put forth ideas on like how there may be a credibility deficit in this statement or any other reflections that you have on this passage? Um, and I'll watch those comments while I also muse a little bit about this. So, what do you think, or how does this magazine profile represent a credibility deficit? Michaela, I'm putting you on the spot. I didn't tell you I was going to do this, but do you have
Oh,
any
sorry.
thoughts
I
on
thought
it?
that
No,
was
no,
gonna
I
do it.
wasn't asking you actually, but I was like,
Yeah.
I would love to hear since you spent time in Tarija with the framework that you did.
Mhm. Mhm.
What do you think about what these first year students are saying?
Yeah, so I mean, essentially saying that they're able to do things that is above the level of expertise and training that they have. Um, and kind of like presenting weirdly this like, oh, it's okay because they were forced to do this because there was no other resources and they had to learn quickly that way. Which again, it's one thing if you're on the job and you're qualified and you have to learn things or limited resources, but when you don't have the training and you opt into this situation, you're essentially putting yourself in this situation and whatever group they're with is also doing that. Yeah, it's incredibly problematic. And again, there is that kind of loses its credibility for, I
Yeah,
think,
for representing the truth. Yeah. So exactly. So credibility deficit in terms of colonial thinking is when a majoritized or more powerful group sees themselves as the focal point of what's happening and solutions, when in reality, we all know that first year medical students are not probably actually the solution for patients with malaria, HIV, or chronic pain, jumping from village to village. There's a whole ecosystem in Tanzania for healthcare practice that has continuity and longitudinality. And these students didn't see any of that, nor did they appreciate that. They really just saw themselves. So they're not giving enough credibility to the local health system. And this can happen often when socially marginalized, disadvantaged, or ignored groups are encountered by majoritized and sometimes higher income folks. I think part of why this happens is because health systems look very different depending on where you are. And so many of you who are in the US, the health systems you're a part of look very much like those pictures on the right. There's glass, there's signs, there's clock towers. It's very clear that it's a health system to you. You walk in there, you go up an elevator, you see things and your mind says, this is what healthcare looks like. What happens is when we pick ourselves up and put ourselves down in a different country that has different resources and is differently resourced than we're used to seeing, the infrastructure may look much more like the pictures on the left. And unless you're oriented to that, like Michaela was in Tarija, where she was placed with a primary health care providers who are dedicated to the well-being of their community, then it's very easy to ignore or underestimate the capabilities of these health systems. And so you can see there on the left, there's a specialty clinic, a primary care clinic, and then the folks in the bottom left picture are actually community health workers, which is an evidence-based and essential primary healthcare backbone. So unfortunately, because our minds are used to seeing what's on the right, we see what's on the left, and we can have a heightened sense of our agency, what we're able to do, and we can discount things that are actually happening locally. We know that healthcare in all settings, but particularly in low middle income countries, can happen in a variety of formal and informal structures. So this is a graphic actually that's based on India's health sector, but looking at delivery subsystems within public, private, and not-for-profit health systems, recognizing that there is healthcare happening at the household level, the community level, health center level, district level, hospital, tertiary hospital level. And if we aren't oriented to this, then unfortunately, we take too much credibility and agency on ourselves as outsiders, and we're socialized to do this. The other thing that we do is our minds will oversimplify cause and effect. And so this is what the oversimplification cause fallacy looks like in imagery. And I was guilty of it as a medical student. You can see I was on the cover of AMSA's then print magazine, glorifying my time in Kenya. It did not mention the local Kenya healthcare system at all. And what happens is when we oversimplify the cause for challenges or opportunities, then our solutions, such as undergraduates hanging out medications, duffel bag medicine, where you're packing medications in a suitcase and trying to take them somewhere, or short-term volunteers being seen as the solution for long-term health systems opportunities, then we oversimplify cause and solution. And we actually, unfortunately, when we're doing this, the opportunity costs are that we're actually ignoring the existing health system. So whereas you may be tempted to go on a international elective that's going to promise you instant gratification and being able to change things instantly, what you're in actuality doing is you are not seeing what's happening in a sustainable way. And so these are images from, actual pharmacy infrastructure that's locally run. Every corner of the earth, even those that are at war, have supply chains for pharmaceuticals and have some cadre of the workforce that manages that. And so my challenge to you would be to try and shift from thinking about your international elective as an opportunity to do duffel bag medicine or medical mission type or brigade approach to really putting yourself in the seat of admirer and giving credibility where credibility is due, which is with the local longitudinal sustainable health system. Another tool and concept that I would encourage you to think about is called asset-based community development. And we don't get to learn a lot about development theory in medical school. But there's basically kind of two main modes of development. One is deficit models, which you may be familiar with because you've done or heard about needs assessments. And so deficit models is where you look at problems that require fixing. You will be asked to do things like a needs assessment, and then you will be asked to propose solutions that fill in gaps or problems. Versus an asset model where you actually map strengths and things that are going well, and then external resources are utilized to bolster those strengths, bring them together to create a shared agenda. And I think, it's very tempting when we go to places that look different than we're used to culturally, infrastructure wise, the perceived standard of living, even the GDP and, the income per capita, they're very different. And it's very tempting for us to emphasize what's going wrong. And what I want to encourage you to do is to find out what's going right. Gonzalo, to illustrate this, could you give us some insights into what's going well in the Bolivian healthcare system that you get to showcase for students?
Absolutely. Thank you very much. Jess. Yes. Well, I would say that the first thing that is going well here is the fact that in Bolivia, health is considered a human right. As a human right, it is also established in the Constitution, which is, the foundation law of everything, that the state is responsible for providing health, education, and some other things. But basically, health. Based on that principle, in the year 2019, the government enacted a law establishing universal health care for all Bolivians residing in the country. I think that is an incredible achievement. Just it has, this is not simple. It's really expensive. It takes a lot of effort. It takes a lot of crowds in the hospitals. Hospitals are constantly crowded, and the students who participate in our programs see that, and they see that all the wait areas are crowded with patients, babies, and everything else in all levels. That's, I think, one great achievement. The governments and different administrations that have been running this system are struggling really hard to find the means and resources to keep the system running. But it is running, it is there, it is improving little by little. And the benefit for Bolivians is incredible because you have the chance to just go to a hospital, show up and say, I need medical attention, and that's it. And you get it, right? From cancer and the most complicated cases of cancer until just a regular delivery, everything is covered. You don't have to pay a dime. There may be some medications that are not available in the system that you have to come up with, but in general, you have the health system and the health attention that you want. That's one thing. Another thing I think that is really important is patients' rights. That is also being enforced in all the hospitals, and that's what is asset-based, basically. And that's what makes our program so interesting because we know and we emphasize this with students that the role is completely observational. And because of that, they are respecting the human rights of the patients and they are respecting the patient's rights. Another thing that I have to mention that I think is amazing is the integration of traditional medicine into the regular health system. This has been done, a while ago, I think around 1985, when that government administration decided to integrate all the traditional practices into the regular system. Today, especially in rural hospitals, patients have the chance to choose the kind of care they want. So they can say, I want something like Western medicine kind of thing, which is what we know we're familiar with, or they could say, I want traditional medicine, and there is a traditional practitioner there. Now, not everyone can be a traditional practitioner. They need a license, and that's something the Ministry of Health issues. They issue the licenses, so they are licensed practitioners overseen by a Western doctor. Another thing, and you were mentioning that in India, is community health workers. In Bolivia, we have something called CFHI, and another one called Mi Salud. Those are teams of PAs, nurses, and other health practitioners, nurses, basic level nurses that go from community to community, providing attention to the patients that need it. So they have like a regular shift when they go visiting the communities on a regular basis. So everybody is basically covered. The system in Bolivia is preventive, and I think that is saving a lot of money. And the CFCs and Mi Salud practitioners are making sure that they are preventing people from getting to a hospital, because when you reach a hospital, when you need to go to a hospital, then the cost of attention goes sky high. So they are preventing the cost from just skyrocketing. Um, those are some of the things. And of course, just another thing that I think is really important is the vaccination programs. The coverage of vaccination in Bolivia is very, very wide. We're reaching around 95% of the population with vaccines. So I think that's also an achievement. And that is something that students see here all the time. They're exposed to those things. They see all the levels. We have first, second, third levels as in the States. So they experience all of them while they are here with us.
Thank you so much, Gonzalo. And asset-based community development was formalized at Northwestern University, and it doesn't mean that resource-restricted communities don't benefit from outside resources, but it does mean that they are mobilized in a more sustainable, empowering way when we look at the lens of strengths and what's going well in order to create a shared agenda around what needs improvement. And CFHI has already done this groundwork for you. So when you land in your international elective, you are already seeing what's going well and the upsides of the health system. And thank you, Gonzalo, for sharing Bolivia's amazing strengths. And I'm jealous of the human rights, the health as a human right framework, because in the US, we certainly don't have that. Other common ethical and effectiveness missteps that I want to highlight is a faulty theory of change. So a theory of change is a fancy way of saying kind of how do you think you're going to go from point A to point D, and what step B, C in the middle. And basically, when we look at like duffel bag medicine and colonized approaches to international electives, we see that the theory of change just doesn't hold up. It doesn't hold up to evidence-based medicine. It doesn't hold up to sustainability. It doesn't hold up to patient safety or accountability. That is often a red flag when you're looking at international electives. If the theory of change doesn't make sense, if it's not what you've seen work in your own hospitals and clinics, not likely it's working elsewhere either. This can sometimes lead to unsafe and unskilled clinical activities, circumventing and undermining local health systems, under or uncompensating local community members for resource utilization. You know, when someone picks me up at the airport, when I stay at their house, when I eat their food, these are resources that are costly. And if I'm not paying for that, then I'm actually further depleting resources. And when you have that credibility deficit where you as an outsider take on a bunch of credibility for saving or changing things, and you don't give credibility to local systems, then you're more and more likely to see yourself as someone who's entitled to things for free. And so this is all connected to making sure that we're practicing fair trade as we do our international electives. I want to talk about some shifts because I think decolonizing your international elective and even the way schools are talking about international electives is so important. Some of the shifts that I would encourage you as individuals, whether you're faculty or students, to think about making is moving from a sense of certainty that you know what's going on in the world or somewhere else to a sense of curiosity. Moving from focusing on your own comfort to realizing that you're going to have to get uncomfortable in order to learn and grow. And so being not expecting and being comfortable with discomfort. Moving from agent to learner, this can be very hard. We're all, many of us in medicine are type A, and so we want to do things and be productive. But really, what one of my mentors says is don't just do something, stand there, or sit on your hands, or first do no help. So whatever kind of reminder you can have in your brain that like being a fly on the wall in someone else's health system is one of the most respectful and most prudent things you can do. Moving from exceptionalism to humility, from superiority to inferiority, you are inferior in a different country in terms of your understanding of medicine, of treatment protocols, of epidemiology, and so much more. Moving from rush to unhurried. So Peter Singer, who's a linguist, once said there's more often a compromise between ethics and expediency. So oftentimes as outsiders, particularly those from the US, we have these really fast timelines. We have a month to go abroad. We're expected to achieve X, Y, or Z. Both ourselves expect that, our families, our friends, our schools. And so it can result in us being very rushed and unfortunately ignoring local tempo, ignoring local achievements. And similarly, moving from a sense that you need to accomplish something to a sense that you need to focus on sustainability and understanding what that is, from simplification to complexity, from deficits to assets, and similarly from critic to admirer. You will see that a lot of these mental shifts have overlaps with the anti-racism movement and kind of white privilege and white saviorism and white supremacy. So I put a resource down there that can be very helpful. And thinking about that overlap is something I challenge you to do. Luckily, these problems with international electives and with us picking up ourselves and putting ourselves down in a different country have been defined for quite a while. And so we have emergence of frameworks. This one's out of family medicine in Canada that start to articulate some of the values and principles that should underlie international engagement, international electives. And so that outside rung of the red and purple is really what I want you to focus on here, not just the somewhat abstract concepts of health equity and social justice, but thinking about for your own behavior, what does it mean to have solidarity? What does it mean to have reciprocity? What does it mean to be responsive and accountable, respectful, honest, open, humble, and to focus on sustainability? Because I think if we make sure we're walking the talk of global health and global engagement, then we can quickly hold up our activities, behaviors, approaches to these standards and start to reflect critically on what we may be thinking about doing. If all else fails, I think thinking about what are your personal and professional goals and are those aligned with getting a job? So this is actually data out of USAID contractors who are now operating under different auspices. But basically, it was a study that looked at organizations who hire US physicians and other healthcare workers. And they were asked, what are the deficits, what are the weaknesses that people have when they've only worked in the US and not worked abroad or not had international experience? What are the weaknesses when they apply to jobs or when they try to do jobs internationally? And the number one weakness that employers cited was that they don't understand the context and realities of global health, which I think underscores the need to be a fly on the wall during your international elective and really deeply try to understand the context and realities without changing them. The next weakness was flexibility, adaptability, and creativity. So thinking about that intra and interpersonal skills that you can develop, particularly when we have to be a little uncomfortable and outside of our cultural norms. That's followed by cultural sensitivity, cross-cultural communication, and knowledge of key player systems and processes. So as you're looking at international elective options, think about, am I going to learn the context and realities? How am I going to do that? Is it nurturing cultural sensitivity, cross-cultural communication? And am I learning about who the players are in global health? There's more built-out competencies from the Consortium of Universities for Global Health and other large-scale organizations, but just to point out some of them here, these are other competencies that you can map your international elective to. And Michaela, I don't know if your elective came up when you were interviewing for residency because you probably interviewed before you did your elective, but I'm interested in, as you move forward in your career, how you would articulate the benefits of the elective for future job opportunities or fellowship or even residency. Did that cross your mind?
Yeah, well, I mean, I would say, yeah, somewhat. I mean, wasn't thinking necessarily, okay, how would it sort of, how would I use the experience? But I think of it more as like how it contributes to my growth as a professional and how I understand things and sort of understand health systems, individuals, and then sort of applying that to my professional life and sort of that sort of taking me forward with doing different things, and being able to take different things I've learned or situations and apply them to professional, personal life, etc. I think for me, the biggest thing, so a little backstory, before going to med school, took 6 years between undergraduate and going to med school. And one of the things I did was I was in the Peace Corps in the Dominican Republic for 2 years. And so I think that having that experience and then being in Bolivia was similar and different in a lot of ways, but I would say similar in the fact that you're being in a place that's it's new, it's somewhat uncomfortable just because, again, new language, new culture. But as you get to know and build relationships with those you're living with, those around you, it kind of shapes and like enhances your perspective on things. So I think for me, really, it's about being able to take all these different insights and just human things from the people that I like got to know there, and have really like an exchange of learning and of sharing and kind of applying that in a lot of different settings. I think as a professional, just working with a diverse group of patients, being able to tap into the thoughts and feelings and attitudes of like everyone you meet across your life is so important. And so the more you build those opportunities, the more you'll be able to relate to your patients, which I think is very important for giving good patient care. So yeah, I would say it's more so that I think it definitely adds for someone who hasn't had that international experience. It's definitely something is to call back on. And I think particularly this program is something that you don't have to be afraid of, and nor should you be. Like, you shouldn't be in a program if you're afraid to talk about it, but you can really like hone in on the values of this program. Before I even left, I remember telling people how impressed I was with, I also did a master's in public health before going to med school. So all these themes of colonialism and white supremacy embedded within global health, I was already kind of attuned to. And the fact that it's brought up here, I think is so important, and also something to relay in your future professional life. And when you think about global health, being able to present those views, whether you get them from this experience or another one, in whatever it is you want to do in the future.
Thank you. Dr. Kateka, could you talk about how you feel like your virtual elective informed or came up as you pursued other professional opportunities, or you will in the future?
Yes, definitely. I think for me, the point at which I am in my career is where I am currently pursuing to do my residency in the United States in family medicine. And this came up because of my interest in public health. I saw I had firsthand experience to see a system which operates on a universal health coverage base, which was in Cuba, where it's health for all, education for all. And so because of that, that kind of embedded the mindset and the mentality that it is actually possible despite the resources. I come from a lower to middle income country, and I practice in a fellow lower to middle income country. And at the same time, I did have experience going to observe this health systems in higher income countries. And so when I did participate in the virtual elective, we talked about a lot of concepts, and we got to see how the difference, how depending on where you're found can really affect your practices, your culture, your ethical background, and how you associate yourself with others in health settings. And these are things that we take for granted, and being in that virtual elective just helps kind of set that base to say, okay, we have a lot of unconscious biases that we don't realize, that our geographical location, the people we surround ourselves with, it all applies when we come and do our different electives or our different practices in a place that's not what we're used to. And so from both ends of the spectrum, it was very interesting to see how sometimes we've spoken, for example, about decolonization of the human mind. And at the same time, we also got to see how even on the other end of the spectrum, being from the lower to middle income country, you also have unconscious bias to those who do come and collaborate for projects that are done in this type of setting. And so because of the virtual elective, it was very interesting to see how all of these things come together and how awareness on both ends for all professionals that are participating in these type of projects is very important. And it also helps to form our professional careers no matter where the setting is.
Thank you so much. I appreciate both of you so much. So when we think about if we're not going to bring medications in a suitcase and do duffel bag medicine and try and be solutions for health disparities in international settings right away or during our national elective, what are we doing with our times and ourselves? And so these are just, me brainstorming a little bit, and some of these themes have come up. But I think really learning more about low-cost clinical reasoning skills, diagnostics, differential diagnoses, utilization of health extenders. We've mentioned community health workers. They actually go under like 30 different names internationally: village health workers, promotoras, community health workers. Gonzalo, you mentioned a term that I'm blanking on, that what they're called in Bolivia.
One group is called SAFSI. It has to
SASI.
do something with intercultural health, something like that. And the other one is Mi Salud. That's the other component of that program.
Okay, great. So community health workers are essential for reaching people where they're located, particularly in rural or dense urban populations. Also looking at the close collaboration of public health and clinical medicine. Dr. Kateca can speak to this from Cuba, where I had the honor to go and see this in action, but kind of how there is not this like division between public health and clinical care, that there's catchment areas and there's record keeping epidemiology that's happening at clinical levels. Maybe you could expand on that a little bit.
Yes, of course. And that's one of the reasons that actually made me do research on the virtual elective with CFHI. It's because usually most of the time med school is set up in a way that is mostly focused on clinical practice. And so when I went to Cuba, starting from the first year, they incorporate public health sciences. And so all the way through your last internship year, you're always doing rotations in public health. And as you graduate in the Cuban system, you're considered a family doctor already. So the way they do it is that they practice clinical health at different tier levels, basically. So they incorporate public health in the sense that it all starts from primary health care, which starts with the doctor and nurse of the community. And so for each community, you have your doctor and nurse's office, which is responsible for a certain population within the community. And then what they call an equipo básico de trabajo, which in Spanish is going to loosely translate to English like a basic team of work. They form a group of about 13 doctor and nurses offices that reports to a clinic of the community. And then that clinic reports to the provincial hospital of that province, which then works together with the National Public Health Institute of Cuba. And so it's kind of the way that the services are set up is in a way that it's all connected and they're not seen as different entities. The minute that you get admitted into the hospital, you come with a referral from your family doctor in the community. The minute you get discharged, you go back to report to the family doctor, who follows you up for a certain period of time, depending on what happened to you in the hospital, and so on and so forth. And then they also practice a lot of preventative medicine, which is doing constant surveys within the community. I got the privilege of being part of these surveys because they start to incorporate even medical students from as soon as first year. You go into the communities, you check for symptoms of common diseases, fevers, checking the well-being of all the members of the population that you're assigned to. And because of that, you do see how the general health of the population has significantly improved and is in quite a good state, of course, because of this system that they have established. So it works hand in hand as compared to separate entities.
Love that. Yeah. And in the US, public health and clinical care are often very separate. There's not a lot of overlap. And so seeing that marriage, international settings can be very helpful. And often it's much more cost effective to do it that way as well. As Gonzalo mentioned, Another important learning is the integration of traditional or alternative medicine, indigenous medicine, and Western biomedicine. Looking at universal health coverage, how does that work, both from a framework and finance perspective, but also from a healthcare delivery perspective? Looking at tiered health systems and like more formal referential health system structures than what we have in the US, cross-cultural care, obviously, and social determinants of health that take on new meaning. I also want to alleviate the sense that you need to go somewhere during your international elective and change things or make things better because you already are, particularly when you're being respectful and being an admirer. This is a study we did in collaboration with Stanford University looking at what are the impacts of students on host or partner communities in the short term when you do an international elective or a similar short-term experience. And we found that no matter what you do, you will have impacts on folks in terms of helping increase English proficiency for everyone you talk to, increasing the prestige of all the institutions that you visit, fulfilling local practitioners and community members' sense of global citizenship. And I have a quote about this, but basically, we help people feel more efficacious, self-actualized, help them feel that their reach is greater because they're impacting students from living far off. You increase the ability of local individuals and organizations to build and leverage networks, and that's particularly true when you work with an organization like CFHI that has a formal leadership structure locally, like the local coordinators like Gonzalo and his colleagues, medical directors, preceptors, etc. And then finally, movement of and access to resources. So there is opportunity when we travel. We have purchasing power. We do provide economic infusion in a variety of ways, and that is seen as an important benefit and something that it's okay to name. In terms of local community members realizing their own global citizenship, I really appreciate this quote, which is from one of our medical directors in India, who said, "As a global citizen of the world, if I'm able to educate a student from any other nation and he feels a little softer about places that are not as economically well off, then from that perspective, of course, is beneficial because we're benefiting some students living in affluent nations to have a balanced view of life." And I think, Michaela, that's kind of what you were getting at in terms of seeing people and picking up on things and having a more balanced view of life and a more nuanced ability to read people who may be from different backgrounds than you. I also want to point out the concept of reverse or reciprocal innovation. So initially this was called reverse innovation, which is now out of favor because reverse innovation implies that regular innovation flows from high income to lower income settings. So it's now called reciprocal innovation. But basically the concept that we can learn from innovations that happen in the global south or happen in low and middle income countries, bring those back to the US, particularly as it applies to cost effectiveness, to universal health coverage, to integration of traditional healing or alternative medicine and biomedicine. So many things, point of care testing, low cost pharmaceutical regimens. There's so much that we can learn and bring back to the US in terms of helping our system work better for everyone and be more cost effective. You know, we spend almost 18% of our GDP, the highest amount of any country in the world, and we have huge health disparities, and the outcomes do not correlate with the amount of money spent. So there's a lot of opportunity for us to learn from others. So what does it look like to partner with CFHI for doing an international elective? I showed you this slide earlier, but just to point out that we have international electives available for fourth year or sixth year medical students throughout the world. And there are certain themes or specialties that are easily accessible. And then I want to just mention that you can also request a different specialization or department that you want to rotate in, and we try to accommodate those as much as possible. We have a robust pre-departure training that includes our 8 modular course pillars of global health, which results in a certificate. We also have Global Ambassadors for Patient Safety, which is in collaboration with the University of Minnesota. We have a huge overview on logistics and safety. and a big focus on supporting you when you're abroad. So ensuring that you have an infrastructure that if you get sick, that prevents you from getting sick, that deals with emergencies, that has your well-being in mind. We also have a strong focus on cross-cultural fluency and effectiveness. We partner with 2 cross-cultural effectiveness leaders, including the COSI group for the IES, which is Intercultural Effectiveness Score, and Aparian Global for the GlobeSmart tool, where you can plot yourself along 5 cultural domains and compare yourself with 102 different countries. We utilize models like the culture tree, which I won't have time to go into, so this is more of a suspense building slide. But Google the culture tree. We really try to emphasize our EQ, emotional intelligence, our positive regard, constitutional factors that can help us be more cross-culturally effective. So drum roll, I know you all came here to learn about CFHI electives. If you're thinking of partnering with CFHI, we would love to partner with you. We have both place-based, which is where you travel to a country, and virtual opportunities. I'm going to have Dr. Kateka speak to the virtual elective for a moment.
All right. So I think, as I mentioned, I was part of the March cohort. And the virtual elective for me, it involved a lot of learning from different aspects of health that are most of the time taken for granted, such as global health ethics, where we learned a lot about the different factors and legalities that play a role in cross-culture between collaborations, where sometimes you may have the intention to help when you are thinking of participating in global health. However, you do have to consider that the place you're going to is not of your own, and it's very important to understand what are the global health ethics, what are the clinical ethics, what are the research ethics of the place that you're going to practice. We also had intersectoral health, which was more focused on the coordination between different institutions in different health settings. It also helps you understand how cultural differences may influence the way decisions and processes may take place. And it's very important to respect what is the protocol of the place that you're going to. And as Dr. Evett said, just settle for being the flying on the wall if you're able. And then community engagement was highlighting mostly the importance of considering the population that you are trying to help, because sometimes it's not always about what you do, but it's how it's received. And so in order to try and guarantee success with the project, or a closer to success of a project, then it's very important to also participate the community leaders. Who is it that leads global health projects in the community that you're trying to implement the project? Speak to those people, get data collection for what the people actually need, despite what you may think you already know. We also spoke about the different processes of human evolution, which is very interesting because evolution is mostly thought of to be progressive and positive. But we also saw how we were mostly affected negatively health-wise by evolution processes and by more plastic usage, more industrial development. And so during that elective, I did get the chance to see how all these aspects come together and are very important to take into consideration as we collaborate in global health delivery.
Thank you so much. And here's a picture of the elective. I will mention that students from low middle income countries have 100% scholarship, and we have students from over 20 countries generally participating. If you're interested and able to travel to an elective, I'm going to overview some of the ones that we offer. The first is in Delhi. This focuses on public health. India surpassed China 2 years ago as the world's most populous country, and as such is responsible for a large percentage of the overall burden of disease in the world. And there has been huge reductions in child mortality, largely in India, because of public health systems. And so this is an opportunity to really get a broad survey of public health, including clean water and sanitation, HIV prevention, harm reduction, homeless youth programs, and drug prevention and treatment. Also understanding a pluriform health system. India has a very complex health system with public, private, nonprofit, and academic institutions. The other rotation in India is in Dehradun, which is in the foothills of the Himalayas, where the Ganges River is. This is a very spiritual location. It's more rural than Delhi. This is looking at the public health for the first week in Delhi, and then you go to Dehradun for weeks 2 through 4, learning about the Ministry of Ayush, which is actual Ministry of Health for alternative treatments, and the integration of all these practices, including Ayurveda, Siddha, Unani, and homeopathy. In the Philippines, the program focuses on remote island medicine. The Philippines has over 2,600 islands, many of which are inhabited. And so the Ministry of Health has set up the geographically isolated disadvantaged areas and has the barangay health stations where you will be posted. You spend the first week in Manila to learn about the health system, and then weeks 2 through 4 on one of 3 remote islands, and understanding how one doctor and a cadre of nurses are taking in and addressing all the health challenges. In Ghana, in Accra, the focus is on pediatric medicine. The rotations are based at Princess Marie Louise Children's Hospital in Accra, which is the largest pediatric hospital in West Africa, has both inpatient and outpatient wards, has a large malnutrition refeeding program, physical medicine and rehab. CFHI has led up work there because we also reinvest community health grants through the tuition dollars that students pay, and we have focused on disability awareness and destigmatization with that funding. This really, I think, helps to show the blend between public health and clinical care. I will also say that Ghana is very powerful in that it is one of the seats of Pan-Africanism and the African liberation movement with Marcus Garvey and other leaders. And so there's a whole backdrop of African liberty and pride and the history of that movement. And Cape Coast is, as it says, on the coast. It was actually an anchor for the slave trade. So there's a very kind of heavy backdrop of the slave trade and learning about the slave castles and how that trade was established. But clinically, you're rotating at the Cape Coast Teaching Hospital. The electives that are pre-packaged are emergency medicine and general surgery, but this hospital has a lot of specialty and general inpatient care. Emergency medicine, interestingly, was started as a specialty in 2009 and was written into the Constitution. And there continues to be work to increase access to essential surgery and emergency care. In Uganda, one of the programs is in Southwest Uganda, which is in Kabale. This is an NGO health system, so very community-based. It's run by Dr. Jeffrey Nguyo, and he was actually a child soldier during the war with Idi Amin. And he put himself through medical school selling pineapples to the aid workers. He has dedicated himself to addressing health disparities through rural outreach, through inpatient, outpatient, through addressing social determinants of health. The other program or opportunity in Uganda is in Mukono, which is a district outside Kampala. This focuses on community health worker training and monitoring and evaluation and is in partnership with OmniMed. In South Africa, there's an opportunity to rotate at a very busy community-based hospital in pediatric medicine or general surgery. Durban is has a large Zulu population. I will mention that many of our electives, you are housed with local families, and for this elective, you are placed with Zulu families, and so understanding the cultural heritage. Durban has the highest HIV incidence of anywhere in South Africa, and so you're getting to see also broad spectrum HIV disease presentations and management. In Cape Town, the rotations are at the Red Cross Children's Hospital, focusing on pediatric medicine, or at Victoria Hospital, focusing on internal medicine. There's also inpatient palliative care there. This program, you're actually living in a township, which is where the Black South Africans were forcefully displaced, and really looking at post-apartheid health disparities and how racism has perpetuated beyond when apartheid ended. In Argentina, you are in Cordoba, which is a large college town, so to speak, beautiful colonial college town. This program focuses on comprehensive mental health care. Argentina had a health system intervention and new law that prescribed multidisciplinary mental health care. So anyone going into psychiatry or family medicine or any, I mean, most of our disciplines do address psychiatric illness. This is an amazing program. I'll also mention that all of our international electives in Latin America include Spanish language training. In Ecuador, the programs in Quito and Puyo. Quito is the capital city. The rotation focuses on maternal health at the large urban maternal health hospital. You do have to have intermediate Spanish to rotate there. Of note, there's a huge health disparity with Indigenous women experiencing 9 times the degree of maternal mortality. So looking at how the health system is trying to embrace Indigenous women, make it more comfortable for them to deliver in hospitals, more inviting. And then Puyo is in the Amazon basin. This rotation is not for the faint-hearted. You actually hike into the Amazon for many hours with the local health team that is addressing the health of the Quechua and Shuar tribes, which are located in the jungle. You have to have advanced Spanish for this rotation. In Mexico, the rotation Oaxaca, this is good if you don't have a lot of Spanish. This can take beginner or really very little Spanish. So there's a teaching hospital in the northern part of the city where you can rotate in emergency medicine or general surgery. And then in Puerto Escondido, the focus is on primary care and public health with a focus on vector-borne illness and rotations at the Centro de Salud, which are the primary healthcare institutions. Gonzalo, I'll have you speak about La Paz, and Michaela, I'll have you speak about Tarija.
Perfect. Thank you.
Go ahead. Gonzalo, you can go first, and then Michaela can go.
Okay, perfect. Well, the program in La Paz is basically focused on pediatric medicine. We work on first, second, third level hospitals. I would like to add that we're working very, very closely with obstetrics and gynecology and women's rights, family planning, in all the things that are related to basically women's rights in family planning. That's a new part of the rotation that we added recently. We have also health as a human right framework, and that's where you're going to see all the system, the universal healthcare system in action. And something that is interesting is the fact that La Paz is located basically at the heart of the Aymara Nation, which is the predominant native nation around us, around the city. So Aymara is for a lot of people the first language, and Spanish is a second language. So you get to interact with a lot of people, and basically all your patients, because you're visiting public hospitals, all your patients come from an Aymara background. So that's very, very, it enriches very much the rotation. And of course, all the trips and the things you do on weekends, even add even more to the rotation itself. So, you get to make sense of a lot of things that you see in the hospitals.
Thank you. Michaela, do you mind telling us about Tarija?
Sure. I also have slides. I wasn't sure. I didn't realize I should send them.
No,
So I
you're
have
good.
them.
Go
I
ahead
can
and pull them
share.
up.
I think
Yeah,
I need
please
to
do.
be. Oh, cool. Okay. Can y'all wait a sec? Can y'all see this? Okay. So
Yes,
yeah.
there you go.
So this is Tarija. So sorry, was on the slide. So Tarija, you can it's good for people of both intermediate and advanced Spanish, or it's sort of like even people who are kind of just getting started or have taken some courses but don't feel super confident. And there are opportunities. There's a lot of different clinical opportunities. There's also opportunities for public health students as well. I spoke to a couple public health students who have been going there, and they're doing different projects there. You can kind of sort of make your clinical experience cater to what you're interested in. Chagas, for example, is a huge is like a big condition. I forget, I'm losing the terminology, but very prevalent. That's what I meant to say. And so there's clinics dedicated to Chagas. There's as well as other infectious diseases, including yellow fever, TB. But you really have the opportunity to experience rural clinics. hospitals, primary care, etc. I have sort of pictures that are more from the cultural side, which for me I think is the other half, if not most most of the half of your experience. So Tarija in particular is like really, and in Bolivia is known for the it's called La Tierra de los Gigantes, like the giants. And so they have all these prehistoric fossils that have been found. And sometimes people will just be building their home and find a skull of like any of these animals. So this is a picture on the far left from the museum that's there. Just me and the sign that says Tarija, just so you know where it is. And then on the left is like a typical sort of sweets that you can get during the festival of San Roque and other festivals, which is the San Roque festival is to the right. And that's this 8-day or more celebration that happens with parades and food and sweets, as you see on the left. And it's the celebration of this saint who was known for curing people, particularly, I think at the time, leprosy was a huge issue. And so the idea was like the saint, helped cure that as well as other maladies. So yeah, it was really cool to see all these things there. And then let's see if I can go to the next one. Okay, yeah. So this is some other stuff to my left. It's my host family. When I talk about the exchange, so I benefited from all of the amazing food that my host family Lila made. And so in return, I wanted to show them some recipes that I knew. So one of them was a tres leches. So we made a tres leches cake. And I also made that with my Spanish teacher, who's the one on the right. And she so in addition to doing Spanish courses, she really tried to integrate you into the things that are around there. So we went to this dam that's a little bit outside of Tarija to explore, which is really fun. And then on the left so Tarija is, I forget how many thousand feet up in the air, but then this area to the left is about 14,000 feet, and it's called the Altiplano, the higher plains. And here you see some like ancient symbols and drawings from, I'm not going to say the time period because I forget. But it was really cool to see that and just an incredibly different landscape. And then on the right, my host brother was on a running club and he invited me to join in on one of the 5K races. And so this was like their whole running club. So it was really fun to be a part of that. I also used to run, so that was a lot of fun and just to be sort of integrated into that. So really, I think my time was both the clinical side and seeing all these different hospital and primary care settings, but then also just like living there, like I would, anywhere. And yeah, happy to answer any questions about that.
Thank you so much. I so appreciate that. And I think the cultural immersion piece sometimes can not be in the front of mind when we're busy medical students and trying to get everything done. But I really appreciate how you, put an exclamation point on that. In terms of applying, CFHI has an application process, and if you go to our website, you can see how to submit an application, and usually you hear within a few weeks. For fourth year rotations, many of them are done between kind of December, January, February, March before residency. And so generally we recommend you apply 3 to 6 months in advance. So start thinking about getting that application in. We do have a tuition because we practice fair trade learning, which means that we're going to make sure everybody who teaches you has an honorarium and or the organizations have reciprocity. But we also do our best to provide scholarships. I will mention that there is a full ride scholarship for rotations in the Philippines. The other scholarships are generally partial scholarships covering your tuition or half the tuition. And then you also need to factor in flight. We do have a crowdfunding portion of the website, so you can use that to raise funds through friends and family and others. So we really try to support and ensure that everyone has access. And for the virtual elective, as I mentioned, we have full rides for all students from low middle income countries. So I know we ran a little over in terms of time, but I think it was well used. Are there any burning questions or comments? And please put them in the chat. And I'm going to ask for closing thoughts from each of our panelists, if you don't mind. Dr. Kenteka, let's start with you.
Okay, so I think the highlight for me was definitely the exchange with all the global health professionals in the field from all sorts of places, because it's one thing to read about the changes in global health, and it's another thing to hear about it like from people who are on the ground and experiencing all these things firsthand. And so that was definitely a big plus for me when it came to the elective. And I think the virtual elective is a very nice opportunity to give to those who cannot be present physically to learn from their electives. I think that's mostly my takeaway from the virtual elective.
Thank you so much. Gonzalo, what are your closing thoughts?
Well, definitely, Jess, I think that, I would like to piggyback on something that Dr. Kateka said. The immersion, the cultural immersion in what you take back home with you is a great gain from this program. You are immersed in culture, and that immersion and the skills you learn from immersing yourself in a culture that is so enriching allows you to be a better practitioner in the United States when you're dealing or when you're treating populations that are different and come from different backgrounds. So I think that's one of the best experiences, in La Paz, in Bolivia.
Thank you so much. And Michaela, any closing thought?
I think both Gonzalo and Kanyata said it brilliantly. I think the biggest thing is that cultural exchange, and what you can take from those experiences and sort of the people you meet. And I still chat with the people that I've met and became friends with in Bolivia. It's not, I think it's, instead of thinking of this, okay, you're this one time you're here for this little stint or whatever, and then you go back to your normal life, whatever that looks like. It's like, no, this is just like any other professional or personal opportunity. You're building relationships that can actually sort of last beyond your time there, whether it's professionally, personally, or a mix of both.
Thank you so much. And that ability to develop relationships across cultural differences or with people whose life paths are different than your own is one of the foundations of intercultural fluency, which we know is so necessary for building bridges and also for addressing health disparities at home and across the world. So I invite everyone to join the CFHI family. Let the world change you. Please reach out. And we would love to have you as an alumni and as a community member, and or just take some of the foundations that we talked about. And as you look for electives or as your friends are looking for electives, start to ask some of those difficult questions and really look for authentic international and global health opportunities. So thank you all, and thank you, Morel, for making this happen. Take good care and be well.